For our next question, an 8-year-old boy presents to the pediatric clinic with a 3-week history of fever and tender lump on his neck. His mother reports that he had been playing with the neighborhood kittens. On examination, there's a 1.5 by 1 centimeter tender erythematous lymph node in the right cervical legion. A small healing scratch with a papule is noted on his right forearm. Ultrasound of the neck shows a lymph node with central necrosis. Which of the following is the causative organism? All right, this is Bartonella henselae. This is caused by cat scratch disease. And this is a self-limited granulomatous infection in immunocompetent children. And usually this presents with regional lymphadenopathy. By the way, let me know if you guys like this layout. I did this because the feedback was you'd like to have the question in the middle. The way to think about this question is in a patient with lymphadenitis, which is just inflammation of the lymph nodes, and after just a minor trauma with a pet, especially little kittens, and with an ultrasound of central necrosis, then you should think of Bartonella. And so what happens here is he gets scratched, and so Bartonella then gets into the skin, and then you have a local multiplication that forms a papule or a pustule at the scratch site, and then the organism travels to the regional lymph nodes, and that causes granulomatous inflammation. There's an immune response that leads to necrosis and supportation within the node. And that just means the formation and the discharge of the pus, right? That thick and whitish yellow fluid that has all the dead white cells that you hate, that. And so in immunocompromised patients, you can also get those vascular proliferating events because Bartonella actually infects the endothelial cells, right? And those are the cells that line your blood vessels. And so it releases the angiogenic factors, which basically tells your body, hey, let's make new blood vessels. Like the key ones are the VEGF, IL-1 beta, and other ones. And that causes vascular proliferation. So you get the abnormal growth of the small blood vessels. And they start to look like little red papules and nodules. And those can easily be confused with Kaposi sarcoma. But yep, this is just cat scratch disease, and so the answer is B. Okay, in our next question, we have a 3-day-old infant born to a mom with O-negative blood type and presents with lethargy, poor feeding, and high-pitched crying. On examination, the baby is jaundiced and has hypotonia. A complete blood cell count shows anemia with hemoglobin level of 12 and elevated retic count. Total serum bilirubin is 28 with the predominance of unconjugated form. Despite phototherapy, the infant's condition deteriorates and MRI shows characteristic signal changes to the basal ganglia. Which of the following conditions is most likely responsible for these findings? So the big takeaway here is that a baby's brain can actually turn yellow. All right, so that's the little baby's brain, and it'll start to look like this. And the answer is hemolytic disease of the newborn. This is kernicterus, and this is a complication of untreated hyperbilirubinemia. So there's a kid, he's getting tired, he's got poor feeding, he's got a high-pitched crying sound, bilirubin toxicity, and the bilirubin level is like 28, right? So that's super crazy, dangerously high. And mom has an O-negative blood type, and so that's going to be a clue for us that there's a suspicion for Rh incompatibility. So if the baby is Rh positive, then there's going to be a maternal anti-D IgG that can cross the placenta and attacks the fetal red cells, and that triggers hemolysis. And that leads to an overload of unconjugated bilirubin. And that then deposits in the brain, especially in the basal ganglia, and that causes permanent damage, right? So phototherapy is not going to be enough at this level. You need an exchange transfusion, and the diagnosis is hemolytic disease of the newborn. All right, congenital adrenal hyperplasia, and that's going to be the the salt wasting, hypotension, and also here you'd see ambiguous genitalia, which we don't see here. Hereditary spherocytosis, first of all, they would probably show you the spherocytes on the smear, but also you'd have family history there. And this is just non-immune hemolysis. And what's happening in our condition is hemolytic disease of the newborn. What about neonatal sepsis? Well, that would be with fever, hypothermia, lethargy, poor feeding. But that does not explain the extreme unconjugated hyperbilirubinemia or the basal ganglion lesions. And toxo. So with toxo, you'd see like the hydrocephalus, chorioretinitis, intracranial calcifications, but there's no mention of any calcifications or any eye findings here. And so this is definitely going to be hemolytic disease of the newborn. And so the bottom line is elevated unconjugated bilirubin and neurological deterioration of a newborn suggests hemolytic disease of the newborn. So there you go. All right, in this question we have a 60-year-old man. He's got a history of alcohol use, abdominal pain, jaundice, and elevated bilirubin and liver enzymes. He's got dilated CBD and ERCP showing a stone in the biliary tree. Which structure is obstructed? All right, so here's what we're looking at. We've got a gallbladder here. We've got the bile duct and the pancreatic duct. There's the pancreas. And there, right there, is the ampulla of Vater, right there in our duodenum. And the structure is indeed going to be C. That's our correct answer. The correct answer is going to be C. And that's where the common bile duct and the main pancreatic duct are going to merge before they drain into the duodenum. All right, so why is it not A? That's proximal to the gallbladder, and that only affects the bile, not the pancreas. Why is it not B, the cystic duct? Will that be gallbladder drainage? That doesn't affect the bile outflow to the intestine, so you'd have no jaundice. What about the main pancreatic duct? Well, that's pancreatic secretion, right? So that would just cause pain, but you wouldn't see the jaundice. And the hepatopancreatic duct, that's usually like just a pretty vague and often just misused term, but it usually refers to the common bile duct near the ampulla, but this is definitely not as specific as C. All right, so there are the associations and the pathophysiology. The gallstone formation, it lodges in the ampulla. You get biliary stasis, jaundice, hepatocyte injury, elevated bilirubin, and liver enzymes. So the obstruction at our answer choices causes the jaundice and abdominal pain due to the biliary tree stone. All right, in this question, we have a 19-year-old female grocery store clerk is stocking shelves when she accidentally pricks her finger with a box cutter. She notices that the bleeding stops almost immediately after applying light pressure. Which of the following mechanisms is primarily responsible for the rapid cessation of the bleeding immediately following the injury? Okay, so for this question, we have to talk about how the body stops the bleeding, and it all starts with vasoconstriction. That's the first reflex after the vessel injury. And so here we got a 19-year-old pricking his finger and the bleeding stops instantly, but that's like way too fast for the clotting factors or the platelets to act. And so what's actually happening is that there's damaged endothelial cells that release endothelin, and that's a potent vasoconstrictor. And that combined with the reflex nerve signals causes the vessels to spasm and also to narrow, and that then slows the blood. And so that gives the body some time to start building the platelets and the clots. But the initial bleeding is going to stop because of the vasoactive substances. And so that's why the answer is the local release. It's that immediate stoppage, which is the vascular spasm, the local secretion of endothelin. Here's the bottom line. Rapid cessation of bleeding post-injury is primarily due to the local release of vasoactive substances. All right, for this question, I just want to go over the pathophysiology of cystic fibrosis. You have 2 copies of mutated CFTR that's needed for the disease. Carrier patients. So we have a 3-year-old boy brought to the pediatrician due to chronic cough, failure to thrive, and frequent foul-smelling stools. Exam shows nasal polyps and digital clubbing. Sweat. Chloride testing reveals a value of 72. Genetic testing confirms we got that mutation of both alleles, which is the best explanation of the underlying defect caused by this mutation. It's going to be the abnormal post-translational folding and degradation by the proteasome. All right, so that CFTR refers to the cystic fibrosis transmembrane conductance regulator. And this is an ATP-gated chloride channel that's found in the epithelial cells, so like the lungs, the pancreas, the intestines, the vas deferens. And this kiddo's got the classic CF problems, right? They got the chronic cough, failure to thrive, nasal polyps, digital clubbing, positive sweat chloride tests, and they even confirm it genetically. And so they're asking, hey, what is the cellular consequence of this mutation? And that's the most common CF mutation. And it's a deletion of the phenylalanine in the position of 508. And so that causes the misfolding of the protein that causes the ER retention and then the degradation, and leads to the absence of the CFTR gene at the membrane. And that causes the thick mucus and the blocked ducts and the pulmonary infections and the pancreatic insufficiency, all of that stuff. So you have no chloride transport, so you get the thick secretions. And you confirm that with the sweat chloride test. All right, so here we have a 45-year-old man who goes to the dermatologist with complaints about an intensely itchy rash, predominantly affecting his elbows, knees, and lower back for the past 2 months. He reports he was diagnosed with iron deficiency anemia 6 months ago, and he has a history of gastrointestinal discomfort that improves with dietary changes. Physical exam reveals multiple excoriated papules and vesicles with crusting, primarily on the extensor surfaces of his extremities and lower back. No mucous involvement is observed. Skin biopsy is performed, and direct immunofluorescence demonstrates granular IgA deposition on the tips of the dermal papillae. Which of the following is the most likely diagnosis? Okay, so we have the itchy elbows and the knees. And so here we should actually think about the gut. So he's got a rash that keeps him up at night. It's itchy, vesicular, and the extensor surfaces is where it's located. He also has iron deficiency anemia and other gut symptoms. And skin biopsy shows the IgA, the granular deposits there in the dermal papillae. That's going to be the signature finding of Dermatitis Herpetiformis. That's the skin manifestation of celiac disease. And so we just pick Dermatitis Herpetiformis and we move on. The answer is C. All right, there are a couple of trap answers here. Bullous pemphigoid would be the tense bulle in the elderly that would have linear IgG along the basement membrane. Linear IgA bullous at the basement membrane. Well, that would be linear, not granular, and it lacks the celiac associations. Lichen planus is the pruritic papules You see the Wickham striae there, so there's no vesicles or IgA findings, so that's not the answer. And then psoriasis would have the silvery scale Auspitz sign stuff. So wrong lesion type, wrong histology. All right, so there's the explanation. Basically, you get those immune complexes get formed at the cross-reactive IgA antibodies because you mistake the skin for the gluten targets. The body's stupid. And the bottom line is granular IgA deposition at the dermal papillae confirms dermatitis herpetiformis, often associated with gluten sensitivity. All right, here's the next practice question. We have a 3-year-old girl brought to the clinic by her parents due to concerns about skin sensitivity in the sun. They reported that her skin appears unusually pale and she's easily developing sunburns after minimal sun exposure. Upon examination, the child's hair is noted to be lightly blonde, almost white, and her eyes have strikingly light blue color. She is hesitant to open her eyes fully under broad examination of lights, which the following best explains the reason for her skin findings. This is definitely going to be a genetic defect. And I've already written out some of this pathway here that we got to know. We have to know about melanin biosynthesis, especially in the context of albinism, which this kid has. She's got the very fair skin, the white blonde hair, the silvery kind of hair. And she's got that sun sensitivity and the photophobia, the light sensitivity. That's due to the lack of the melanin in the iris and the retina. And so this is going to be a type 1 oculocutaneous albinism. And this is most commonly caused by a mutation in the tyrosinase gene, TYR. And so our answer is enzyme tyrosinase. Let's talk about these other answers. So the autoimmune destruction of melanocytes would be vitiligo. That's the localized depigmentation. That's acquired patchy, and you would have normal eye and hair color. Disruption of the migration of melanocytes. That's in Waardenburg syndrome. So not it. Decreased number of malignant melanocytes. That'd be like a nevus, like a birthmark. And the melanin distributed to the dermis. Those will be the bluish patches in the infants, not the generalized hypopigmentation. And so what happens is you have a mutation here in this TYR gene. So you have defective tyrosinase. And so you can't convert the tyrosine to dopa to melanin. You just can't do it. So the melanocytes are present, but they just can't synthesize the pigment. And so the result is hypopigmentation of the skin, the hair, the iris, the retina. And so you get photosensitivity, increased risk of UV damaged DNA, and also some visual issues due to that absent melanin. And so that genetic defect causes albinism, leading to pale skin, light hair, and increased sun sensitivity. All right, last I want to talk about ARR. So here we have a 60-year-old female with hypertension, type 2 diabetes. Her medications are metformin, lisinopril. Study compares the new drug to the placebo. Placebo, 20% experienced MI, and the group receiving the new drug, 15% did. And so the absolute risk reduction is going to be 20 minus 15, so it's 5%. Yay. And really the one thing I wanted to let you know about this one is that if you do 1 over the ARR, then you get the number needed to treat. So there you go. It's that simple. Absolute risk reduction would be 20% minus the 15 equals 5. Hopefully you guys found this interesting and helpful. Now I'm going to create a song so you guys can listen to recap all the high yield information. And if you like this, then like and subscribe. We'll see you guys in the next video.
Yeah. Firm neck fatigue, she's feeling cold. Lymphocytes attack and thyroid's uncontrolled. Anti-TPO, hurt the cells on deck. Hypothyroid swag, keep that T4 in check. In autoimmune hypothyroidism, lymphoid infiltrate. Phagocytes eat but can't kill the staph. For the pH oxidized missing from the path. Catalase positive bugs stay alive and spread. Neutrophils work but ROS is dead. And the PF50 deficiency. CGD impaired ROS killing. Yeah. Girl got a node and a scratch on her hand. Axillary swelling she don't understand. Gram neck plumorphs under silver's glow. Bartonella in the blood, let the fever flow. Leg cat scratch disease and necrotizing granulomatous lymphadenitis. Yeah. Rhyme mismatch, bilirubin flying high. Unconjugated trouble, basal ganglia cry. Exchange transfusion trying to clear that flame. But bilirubin bound got a deadly name. Hemolytic disease of newborn born and conjugated bilirubin-kernicterus. She got gallstones blocking ducts that meet at the ampulla of the inflammation heat. Lipase elevated pain hits the back, ERCP for stones to get her on track. And gallstone at ampulla and acute pancreatitis. Yeah. ES preserved but the ventricle stiff. HTN made that myocardium thick. Yeah, S4 knocking, lungs got rails. Left heart failure with diastolic nick. The lip blood tries to spill, but adrenaline tightens up the drill. Vasoconstrictions first to act, fibrin comes later, that's a fact. Link immediate vasoconstriction, post-injury, endo then release yippee. Sibling got CF, so check your draw. Parents both carriers, that's the law. You ain't sick, so you ain't AI. Leaves 2/3 chance that you carry that flaw. Lame carrier risk and unaffected sibling. One sibling has CF. Herpetiformis rhyme, I'm gluten flaring rash on that butt and knee. Papulas, vesicles, itchy as can be. Iga in dermopopuli stay. Treat with gluten free and dapsone spray. Dermatitis herpetiformis. Ike at dermopopuli. Sock with celiac.